Okay, good morning, everyone. We are very happy to have Hamsa Bastani as our first speaker. She will talk on border testing.
Thank you. Hi, everyone. Thanks for coming. I know it's crazy early in the morning, but I came from the East Coast, so I'm feeling pretty good. This is joint work with Kimon Drakopoulos, who will actually talk about this in 2 weeks in the data-driven workshop, which is probably going to be better. So I encourage you to go check that out. Vishal Gupta from USC, Ioannis Vlachogiannis, who is actually an entrepreneur who was a software architect for this tool that we were deploying. And then the rest of the co-authors are actually members of the Greek COVID-19 task force. So they were obviously instrumental for us to understand the epidemiologist side and also like the policy side for getting this deployed. So this works. Just to kind of set the backdrop a little bit, we got involved in this project in kind of early 2020. So early 2020 is when we were all finding out about COVID for the first time. So a lot of countries kind of went into lockdown. So Greece actually went into lockdowns of different stringency levels between March to May 2020. But tourism is actually 25% of their GDP. So staying in lockdown was had pretty harsh economic consequences as they were going into that first summer like tourist season of 2020. And so they decided that they were actually going to open their borders on July 1st, 2020 for non-essential travel. So basically letting people come in to spend money and kind of keep the economy up and running. But then, of course, the flip side of this coin is the public health consequences of this, right? So now you might be very worried that you are letting in a lot of infected and asymptomatic travelers into the country. They're going to be partying on beaches and clubs, and they might be infecting other people in the population, and that could lead to a public health crisis. So ideally, what you would do is you would just test every single person who's coming into the country at the border. If they test positive, you tell them, hey, you got to quarantine, please don't party. If they test negative, you say, go crazy, spend as much money as you can while you're here. Our economy needs it, right? But unfortunately, at this time, people were very reliant on PCR testing. So we didn't have rapid testing kits of reasonable accuracy yet. And PCR testing supply chains were very strained. So it was very difficult to expand capacity, pretty much impossible. And so you could only test a small subset of travelers. So what we decided to try and do, Kimon, Vishal, and I, is to try and,
Why do you call it the conservative approach?
What is
the word conservative? What does that reflect?
Like conservative from a public health perspective, like they had followed, they had gone into lockdown, right? And so there's a trade-off here about having like public health versus economic activity, right? So they were conservative in the sense that they were limiting infections originally by going into lockdown that were fairly stringent, and then that limited economic activity, but that wasn't sustainable as like the tourist season was approaching.
Wuhan did the same thing too. They went in lockdown for like 76 days. Wuhan in China.
Yes, so China is like a whole other level. I think most people would say that China's approach has been heavily conservative. Yeah. I mean, they limited activity to the point that people weren't allowed to leave their homes. I don't think that would fly anywhere else. Yeah.
Still, I don't understand the word conservative. What would be the opposite?
Sweden.
To what we're doing now, we're not having Sweden. Yeah.
What would you
So
call
the
that?
liberal approach is to...
What would you call the opposite of conservative?
Not having any lockdown or regulations.
Oh, okay. Sorry.
Yeah. So I think Spain also did this, right?
So every place that went on lockdown basically said that's.
Guys, you have to ask for the microphone if you want to ask an important question.
Sorry.
I was going to say, so your definition of conservative approach is every location on planet Earth that went on lockdown, community lockdown, is conservative. If people have to stay home.
Yeah, I wouldn't read too much into that. That's just to give you some background. That is not what they continue doing. They opened their borders. So we're trying to like, have this nice trade-off between having free activity, but then also, trying to keep the infections under like certain safety level. But yeah, at this point, I guess like in this context, we would refer to any place that had like a stringent lockdown. So limiting people's mobility and activity to like reduce infections as
conservative. You see, I think people are confused because in the US, conservative means you don't even believe that the virus exists.
Yeah, sorry. So probably not the best usage of the term.
over to you.
Other questions or comments? I did not expect to spend this much time on this slide, so that's great.
Okay, I will try to tame the audience.
No, this is great. That keeps me awake. So, so the solution we propose is a tool called AVA. So this is basically a platform. It's a real-time data-driven system that allocates the limited testing resources that we have with PCR testing supply chains to kind of get the most bang for our buck. So if you can't test everyone, ideally you would test people who are most likely to test positive with the hope that you will find and catch the most infections and get them to quarantine, right? So that would be the safest approach given a limited testing budget. And so primarily what AVA does is it basically uses machine learning to recommend who to test. Because this was like a fairly large like financial and technical investment from the government, like it was also used to inform like some downstream decisions. So for one thing is that the office of the prime minister would basically like monitor like the infection risk of different countries. And if one place looked like it was getting too risky, they would basically get gray listed. So that means that they have to, any arrival has to produce within the last 72 hours a negative pre-PCR test showing that, you know, they were actually testing negative. This was very difficult to actually do because PCR testing resources were very limited. And so like this is basically like a hammer, like arrivals would tank after a country was gray listed. Of course, infection risk would also tank. So it's not an ideal decision to make. It also has various political consequences. So this is not something we optimized for, but it was something they used the estimates for. And it also offered various like interpretable insights to the Greek government in the sense that they would use these risk estimates to figure out like where they should deploy like ad hoc mobile testing teams or social distancing rules and so on. Questions? Cool. So let me just overview a little bit. So we get about 30 to 100,000 passengers who arrived every day to Greece during the summer of 2020. So this is actually much lower than like regular tourist seasons because it's a pandemic. And they arrived through 40 different points of entry. So it could be like by boat, by land, or by air, but mostly by air. 24 hours prior to travel, families fill out something called a passenger locator form. So this basically serves to collect various features like where they're coming from, their origin location, some demographic information, and then some information that's used by the contact tracing teams in case they test positive. The primary feature we ended up using that was actually predictive was the origin location, so where they're flying in from. So it's a GDPR compliant feature that actually was like pretty predictive of how risky you are of testing positive at the airport. So all of this gets fed into our system AVA. And like I said, unfortunately, the testing capacity is quite limited. So most people don't get tested. About 7,500 people per day would actually get a QR code to get tested. Yes.
So people travel without testing first?
Yeah, all of these, almost most of these people would travel. Oh, yes.
So people could get on a plane without testing because usually in that summer you needed a negative test to board a plane, right?
I don't think people needed a negative test yet.
I think that's what she called gray listing. So if you needed to test to board a plane, you were gray listed. And Greece did want all the tourist partying, so they didn't do that.
So during the summer, yeah, that's great. During the summer, we gray listed, or the Office of the Prime Minister gray listed about 10 countries. I think the testing requirements shot up for certain countries, like the US had one for a while about coming back to the country. At this point, it was very difficult to get a test, like early 2020, right? And the US Americans, for example, weren't even allowed to go into the EU. So it's sort of a different time.
What would you call American blacklisted or gray listed?
We were blacklisted, yeah.
I see. So gray listed means you can go in with a test, blacklisted you just can't go in.
Yeah, so blacklisting I think was decided by the EU at the EU level. So a lot of countries just weren't allowed into the EU. And then gray listing is basically they're in the allowed list of countries in the EU, but then Greece decides that they need to produce extra documentation like a negative PCR pretest. So about 68,000 of these people will get a QR code from us saying that they should get tested. So they jump behind one of these curtains, like this is at the airport, to get their swab taken. Their QR code gets scanned and it gets linked to their sample. That gets put on some truck, which gets shipped off to a lab. And basically we had contracts or agreements with 32 different labs saying that they would submit all their results back to the database with at most a 2-day delay, right? And so that information will go back into AVA, which we use to update our predictive models to make the next set of test allocations.
So I have a question. So the PCR test, they are sort of, did they tell you the number of cycles also, or just the positive or negative?
Just positive or negative, yeah.
Because I think in the EU, they would actually report the number of, they would, in the US, you can't even get the number of cycles, whereas in Europe, you usually could get them, and the more cycles you need, the lower your infection risk is. But you didn't learn those quantitative measures.
No, there was a fairly standardized process.
No, they use pooling for testing, so pools of 5 to 10, but only binary answers.
Okay.
But before the result comes back, you just let the visitor in. Like you're not using it to decide if the visitor can go in or not.
I think technically they were supposed to kind of isolate for the first 2 days. We don't know that anyone did. But yeah, technically they're supposed to like wait for their result to come back. But you know, it's very hard to kind of monitor these things, especially with GDPR. You know, it's not Singapore where you can track their cell phone or something. Cool. So you guys probably already know this, but this positive feedback loop here is kind of critical to making AVA work well. Basically, you know, we're actively collecting new data at the border on every type of passenger who might come in. And that lets us stay agile in responding to how the epidemic risk is evolving over time in different parts of the world. So it was like a highly non-stationary process. And so kind of having this active feedback loop is very important to being able to make good testing decisions and following those spikes closely to, you know, preserve public health. So this is a fairly large scale operation. Like I said, we scaled 40 points of entry. There were about 400 medical professionals and 300 border agents. There were 32 labs. There were a number of dashboards that we designed to like basically communicate this information. And there were constant meetings. There's Kimon with the Greek Prime Minister Mitsotakis, like kind of translating this into policy recommendations. He's very proud of this picture. But so this was sort of like there were a lot of people sort of involved in making sure that the estimates that we were getting were actually being integrated in a reasonable way. So let me just go over the objective, like the mathematical objective first. So like I mentioned, the most predictive feature that we had was the origin location of passengers. So this is a very high dimensional but categorical variable. So you can think of segmenting passengers into kind of discrete types. So I'll talk a little bit about how we deal with the high dimensionality later, but for now, just think about it as like maybe country level, right? So we have like Americans, but not really because America was blacklisted, but you know. So for every type of passenger, we have a test outcome that we model as a Bernoulli random variable with some expected probability of testing positive RK of t. So you'll notice that it depends both on the type K as well as a time step t, because again, it was a very non-stationary process, right? So like a place can spike and then go back down, you know, in risk, you know, about a week later. And importantly, RK of t is unknown. The main decision that we're making is how many passengers to test and KE of t. So how many passengers to test on a given day t of type K at entry E. So there are 40 different points of entry. You can't really move your testing budget around easily, right? So that means our objective, if we want to maximize the expected number of infections caught, is actually really simple. It's the number of people we're testing times the probability that they will test positive, summed over all the entries, all the types, and all the days in the summer, right? So you can already see, like if we knew RK of t, this is a pretty trivial problem. I'm just going to allocate all my testing budget to the riskiest passengers, so people who have the highest RK of t, until I run out of testing budget, right? So this is what we're saying about getting the most bang for our buck. We want to test the people, we want to aggressively test people who have a higher likelihood of testing positive. But of course, the kicker is that we don't know RK of t. And in worse, our estimate, our CAT KFT kind of depends on the testing allocations we made in the previous time period, right? So if we don't test any Spanish passengers for 2 weeks, we're not going to have any data to estimate our CAT KFT. So if they do become super risky, like that's a big blind spot in our algorithm, we wouldn't even know, right? And then these are the constraints. We basically have to respect the testing budget constraint at each point of entry on each day. So we don't want to overload labs because then they won't be able to satisfy our 2-day guarantee. And then we also, I'll talk about this later also, but like arrivals are not kind of uniformly spread across points of entry, right? Like certain types of people might be more likely to show up at certain ports. So you have to make sure that there's a match there too, but I'll kind of get to that later. Yeah.
Can you use side information like use data from Britain and British travelers?
Yeah, so we actually tried really hard to do
Hamsa, maybe you can repeat the questions.
Oh, yes, sorry. So Elon asked, can we use side information, like information about testing results from Britain, for example, to make our estimates better? So first of all, we need like kind of a unified source of information. So we looked at this like our world in data, where people were reporting like every country's like testing rates, like cases, estimated cases and deaths. Surprisingly, we found that it had no signal about the risk of people showing up in Greece. And I'll talk about this later, like the results are kind of surprising to us at least. There's a lot of reasons, like one is that there's like a population mismatch, like the people they're testing are typically like older, like symptomatic, like risky individuals, whereas the people coming to Greece on vacation in early 2020 are not those people. But also there's a lot of censoring depending on a country's testing resources. We don't have visibility into that. So it turned out that for us, like we trained a bunch of models. I'll show you later. They got like 0.5 AURC, so there was no signal. But that's an excellent question. That was our prior to. Other questions? Yes.
It seems like your risk does not depend on the point of entry. So the entry point doesn't really play a big role, except that you cannot test more than arrive at entry, of course. But
yeah,
like the K is more important than the E.
Yes. So there is
No, you have to repeat the question.
I'm so bad at this. So the question was, our estimates RKFT, we've assumed like don't depend on the entry point. So I'll say two things. So first of all, yes, that is so the assumption is that the primary feature we're using to predict someone's risk is where they're coming from, not necessarily the entry point they're coming into. This is sort of a bias variance trade-off issue, because if we actually like the data I'll talk about later already has like very, very high variance because very imbalanced outcomes, very high dimensional categorical features. So if we further split it by entry point, we wouldn't be able to get a signal. So you can think of this as we're injecting a little bit of bias to get a variance reduction by pooling across points of entry. But mainly all the results I'll report use inverse propensity weighting, which is model agnostic. So even if this model is like somewhat misspecified, we'll still get an accurate counterfactual. Yes.
And you assume that these rates are exogenous, right? Like the policy decisions are not going to impact the arrivals.
Yep. Yep. And we have no reason to believe that like Greece's local airport, like border testing policy is going to affect the risk of future arrivals from like the UK or something. Right? So
you're not worried that there's a rumor, nobody tests at the harbor in Athens. Let's just go all in there because then we can get in.
Yeah, that's sort of the assumption. So I'll also say, I think like the testing budgets by entry point were, not public. So this is not something that people should be able to figure out, right? But yeah, that's the assumption. Other thoughts?
So are you adjusting for sensitivity and specificity here?
Are we adjusting for I'm repeating the question. Are we adjusting for sensitivity and specificity? So one really nice thing about using the banded arms is that every location is using the same test, right? So we have a fair comparison, like they all have the same sensitivity and specificity. And so if we're ranking like two different countries, it's an apples to apples comparison, right? Like we're not interested in the actual risk, we're interested in the cardinality. So all I want to say is if I give like 100 tests to Spanish travelers and 100 tests to German travelers, who will have kind of more risk, right? So as long as the test has the same properties, like we don't need to adjust for that for our purposes.
Also, these were PCR.
Yeah.
So the were pretty accurate tests. We didn't have rapid tests here.
He said these are PCR.
But I would argue that even if we did rapid tests, like for this formulation, like that's not necessary, right? Because we're estimating RPFT with the same kind of noisy signal. So you can just think of this like in a bandit, you always get noisy outcomes, and that's fine, right? As long as they all have the same noise. If some entries had worse sensitivity and specificity, that would be a concern, but that's not the case.
So across the countries, just because of the weather, because of various other external factors, you may have a little bit of variation in the way in which these tests are administered. Right? For instance,
we're not looking at countries tests; these are all Greece's tests. Okay. Yeah, sorry, that was the point I was trying to make. So like all the tests are the same because we are administering all the tests. But definitely, if people are coming in with their own test outcomes, this kind of goes back to Elon's point a little bit. It would have been hard to incorporate information from other people's tests because they come with different.
Yeah, so there's been tremendous amount of research that sort of indicates that depending how you calibrate some of these measurements, you may have very different results, and that might not be comparable. So I guess this is not a problem in your particular.
Right, because we're like using the same labs and like the same standardized protocols. Like for example, all the group sizes were also the same, like, that the hope is that there is. Yeah.
Sorry to have to ask you a follow-up question on the, and it is my.
No, I
couldn't fit. Okay, sorry. No, sorry to have to ask you a follow-up question on the specificity and sensitivity that Greg asked. So if I'm infected today, okay, and I arrive in Athens today, okay, the chances are all the tests will not detect me as positive, because it depends on the viral load and all of that. So, and that's really, so unless it's like a DNA type of test that can detect, and even when you have very little amount of the efficacy of the testing is compromised in the sense that with COVID, we know asymptomatic and pre-symptomatic are the main drivers of the epidemic.
Right.
And we're not able to detect them because the tests are not able to detect someone who just got infected today, yesterday. So you let them into the country and then 3 days later, they are highly infectious.
Yeah, that is actually exactly right. So that was one of the reasons, like, so when we started, we were thinking like, should we include like the flight information, right? So because people could have gotten infected on the plane, and you're right, like if they got infected on the plane, we wouldn't be able to detect it at the airport anyway. So you should not think of this as a way to get all of the infections. You should think of this as a way that if I constrained you to say you can do some testing at the airport, how can you best kind of maximize public health, right? So there's a lot of logistical constraints here. Yeah. But absolutely right. Yeah. Other thoughts?
I think you should try to. We should let her go through her slides.
All right. I don't. Okay, so I'm going to start off talking about the test allocation algorithm. So there's an exploration-exploitation trade-off here, as you have probably figured out. So on one hand, you want to test enough passengers of every type to kind of do surveillance, right? So that you know whether or not they're risky, you don't have blind spots. This is also useful for like gray listing decisions. So we can tell the office of the prime minister, hey, this is Malta's risk. Whereas if you did like random testing, you might not have allocated any tests to like a tiny country like Malta. And the other side of the coin, of course, is that I'm interested in exploitation. So I want to actually use these estimates to test arrivals from the riskiest types, aggressively test them so I can find and quarantine the most positive cases. And this is a very well-studied problem. You can use, upper confidence bound, Thompson sampling, Gittins index. We actually built off of a Gittins index-based policy because we wanted to try and get those leading constants right. But in kind of back tests, you could have used anything. They're all kind of the same up to tuning, right? So just to illustrate what this would look like in a classical bandit, like imagine that we just have two types of people, Spanish travelers and German travelers. This is a fake example, just for illustration. So here I have a point estimate for risk, and I also have a 95% confidence interval. So it looks like maybe Spanish travelers are riskier than German travelers, but I really don't know because I have so much uncertainty around my German travelers. And so what a typical bandit algorithm would do here is first it would do an exploration test. So we allocate a test to a German traveler, we swab them, we get the test result back, we update our posterior. So now we're like pretty sure Spanish travelers are riskier than German travelers because I got information, my confidence interval shrunk, my point estimate shifted a little bit, right? So now typically a bandit algorithm will move on to exploitation. So we'll allocate a test to Spanish travelers. We again update our posterior and we kind of continue, right? This is how kind of any bandit algorithm would work in this setting. We use this optimistic Giddens index because I think I'm running late. I will skip it. But basically it's an index-based policy. You compute an index and you pick the arm with the highest index. You can also think of UCB as an index-based policy of a mean plus like some sort of standard deviation. Okay, so there's a couple of challenges here that you probably noticed. So first of all, the estimates that we have are highly non-stationary, right? So we don't want to be making decisions about who to test using like a month-old data. So we asked the epidemiologists on our team and they kind of said like 2 weeks probably seems like a reasonable window. They were actually remarkably close. So we did like a back test to minimize like, out of sample error, and 10 days is actually kind of the optimal window. So they were very close. So basically this was easy. We just discarded any testing results that were over 2 weeks old in terms of computing our estimates. But where the problem starts is like when you have to think about batch decision-making and kind of delayed feedback. So it's not like the little picture I showed you in the sense that, I conduct a test on you, I immediately get the results back, right? So what actually happens is we get the entire passenger manifest at the start of the day, and then we make all our testing allocations for that day. So it's not, real time changing what the decisions are. But even if we could, it wouldn't be that useful because we have delayed feedback, right? So I don't get the result back right away. Someone puts it on a truck and then it gets shipped to the lab, and then, the lab has to process it, and then we get it back like 2 days later, right?
So you said you did pooled testing, right? So
Yeah.
so if one of them was positive, did you then have the original test so you could find out who it was, or would you now have a mixture of one Japanese, one German, one Spanish, or would you pool by nationality? How did you deal with that?
Yeah, we actually talked about this when we were starting, but that was just too logistically complicated. So like being able to, so they basically throw all the swabs into like one pile that gets put on a truck. So if not, you'd have to label them separately based on like, and try to pull them and optimize how they're pooled. And that was just logistically too challenging. So the contact tracing team would follow up with all 5 of those people. And that's how they would figure out like who was tested positive, and then they do their little decision tree thing from there.
So they with all those 5 did other testing later.
Yes.
But you didn't learn whether that was actually the Spanish or the German in your pool who was the positive one. You now actually changed both your German and your Spanish prior, even though it turned out it was the bad German who got positive.
Yeah, so we get those results back from the contact tracing team. So we wait for that. Yeah.
Wait for that. So
Yeah.
you actually, okay, so you don't, okay, so it's not 2 days later, it's 5 days later.
That's part of the delay, sorry. Yeah. That's a great question. And then finally, we have a bunch of constraints. So each point of entry has like a different arrival mix and a testing budget. So I'll talk about that later. So let me just illustrate like what goes wrong within a batch if you try to like just do the standard. Yeah, sorry, guys. Oh, I thought you were gonna say something. Within a batch, if you try to actually go ahead with this, right? So imagine that you had 4 types of passengers. So for each one, I've gone ahead and computed their indices, lambda 1, 2, 3, and 4. Index-based policy will say, okay, I'll test the type 1 passenger. So I allocate a test. And then like nothing happens, right? Because like I'm inside my algorithm and no one has actually arrived yet. And so I don't have any updates to my index-based policy. So what's going to happen is if I just naively follow this, I'm going to keep testing type 1 passengers until I run out of type 1 passengers. And then I keep testing type 3 passengers. So I'll over-explore like one type or a few types while I'm waiting to get the testing results back. And you might say like, okay, so from a theoretical perspective, this actually doesn't matter because it takes 3 days for this batch to complete, right? Like 1 day for the batch to end and 2 days for me to get the results back. So that's a 3-day delay. So if you're thinking about large T time horizon, this is just going to sort of like disappear, right? But for us, because we're in a highly non-stationary setting, like our data is only useful in a 14-day window because every 2 weeks we discard everything, right? So that means that 3 days is actually a huge chunk of my effective time horizon. And so it's not really feasible for me to keep making like suboptimal decisions for so long. So there's kind of this literature on batched bandits, but they typically follow, they don't really work in non-stationary settings. They kind of work in like an explore then commit type strategy. So I uniformly allocate all my exploration samples to like a bunch of arms, wait for the feedback to come back, and then I commit to an arm. But in our setting, because it's so non-stationary, we need to think about how to weave in exploration and exploitation kind of seamlessly within the same batch, right? So what we came up with is something we called certainty equivalent updates. It's actually very simple, right? So the issue is that I conducted a bunch of tests on, say German travelers, and it's on some truck somewhere waiting to get to the lab, right? But unfortunately, I don't have that information yet. So it looks like my estimate is really high variance. So my bandit keeps wanting to explore, but I know that I'm going to get a bunch of reduction in uncertainty in about a day or two, right? So what we do instead is to just simulate the expected reduction in uncertainty. So imagine that you have a beta posterior with alpha k successes and beta k failures, and then I allocate a test. I'm going to actually increase my success and failure by kind of one expected success and one expected failure. So what this does is it keeps the mean the same, but it reduces the variance by kind of the information you might expect to get from one test, right? So we're going to call these pseudo Gittins indices because they do dynamically update.
Wait, why does it keep the mean the same? Because
we normalized it in a way that it does.
Oh, I see.
Yeah.
Good.
Because we haven't gotten any information, so we don't want to change the mean. But we do want to like basically say like, okay, the variance should go down by like one effective test. Okay. So if this was half success, half failure, we would just add like half a success and half a failure so that the mean stays the same. Cool. So if we go back to this picture, it's actually really simple. I allocate a test to a type 1 passenger. Now I do an update and that index will go down. It will always go down because the mean is the same, but the variance has reduced, right? And now my algorithm will actually like move on to a different type. So the nice thing is that it will allocate basically the estimated minimum number of tests to reduce uncertainty for any arms that have high variance. And then all other tests will kind of go to arms with high mean because once the variance is controlled, then the indices kind of stop changing as much, right? Which is exactly what we want for any bandit algorithm. You want to explore and then you want to exploit. So here are some actual results from one of the batches that we ran. So everything is anonymized because it's real data. But on the x-axis, we have like different types. So you can think of these are country or city identifiers. We've ranked them from low risk to high risk. The bars show you the number of arrivals and the teal portion are the number of people who've been tested. So you see exploitation because everyone gets tested on this like high risk tail. But then you see exploration in the sense that, like there's a small number of people being tested in every bar, right? So we're doing like surveillance, right?
That the tourists came from the low-risk countries, it seems.
That's actually by design because the US was blacklisted. So whenever you see one of these big bars shifting this way, they get gray listed, or the EU might actually blacklist them. So that was part of what was going on. Like we saw Malta was like, okay, Malta's not big, but like we saw some countries shifting over. We alert their office of the prime minister and they require negative PCR pretest. And so they will come back here. Sorry, I keep forgetting to repeat the question. Cool. So usually people will ask me why this bar has so many exploration tests because it is the lowest risk bar, but we're still testing most of them. And that's because of the constraints. So this is a map of Greece. So we're not very creative. So if it's a plane, it's an airport. If it's like an anchor, it's a seaport. And if it's like a car, then it's a land port. So these are different points of entry. Some of them are omitted due to privacy, national security reasons. And the coloring is basically showing you like how test rich they are. So if it's like blue, it means they're very test rich relatively. And if they're red, that means they're test poor. So like it actually matters where we test people because some places have more ability to test than others relative to their arrivals. And also some people only show up at some arrivals. So Germans probably guessed, is like one of the big low risk bars. So they came in huge numbers to all points of entry, and they were great because they were super low risk the whole time. But if you look at Northern Macedonians, which are MK, you can see that they only arrived. So here, red or orange means that like density. You can see that they only arrived to a handful of points of entry. So that's because they're coming in through the land ports. They're not coming in as much to the airports or seaports. And so if you want to test a Northern Macedonian, you better save testing budget like entry 40 or something like that. If you waste all of that on Germans, then you've made bad decisions because you could have tested Germans anywhere else. Right? So what do you do? Okay, so like so far our algorithm is basically saying like you choose the type with the highest pseudo Gittins index and you find a passenger to test. But basically what we're saying now is like you actually like it matters like where you choose to test them because you might want to like save tests at certain ports for like unique types. And this feels like one of those online matching problems where you solve like some big LP. We didn't know how to do that with our certainty equivalent updates. And we were under a time constraint, so we just went with a simple greedy heuristic, which is that we're just going to test a passenger of type K. If we want to test a passenger of type K, we just choose someone at the port that has most remaining tests available. You know, so if Germans are coming in at like point of entry 1, 2, and 3, and 3 has the most tests, then we'll, you know, choose test port 3 with the hope that, you know, we save tests at like more constrained ports for like unique types. But I think there's probably some sort of academic thing here about how to integrate certainty equivalent updates with, you know, this online matching sort of problem. So the algorithm is super simple and it's very computationally efficient. Basically, we get the passenger manifest at every port. So like I know their type, passenger ID, the port they're coming to, and how many tests are left. For each type, I compute a pseudo Gittins index. So now I'm going to say, oh, type 2 has the highest index. I'm going to test the type 2 passenger. There's 2 type 2 passengers showing up, one at port 1, port 3. I'm going to pick port 1 because it has more tests. I cross this person off. I do an update. Now that index has gone down. So I'm going to test the type 1 passenger. They're only coming in at port 3. So good thing I didn't waste the port 3 test. That's an artificially constructed example, but you know, you kind of get it. And we kind of run this until we run out of tests. Any questions about? Cool. So the other side of this coin was like estimating the prevalence. This probably goes back to your point of entry type question. So a big challenge here is that we have very imbalanced outcomes. So if you kind of randomly test, you know, 500 people at the border, only 1 person will test positive, which is great from a public health perspective. If it's a lot more than that, it would be very irresponsible to open your borders. But from a statistical perspective, it is not great because even though you're testing like thousands of people every day, you're really only getting like a handful of positive outcomes. So like, how do you do inference with that, right? And on top of that, the main feature origin that we're using is like pretty high dimensional because there's many different cities people could be coming from, right? So if we actually looked at testing data, like, you know, 75% of countries had less than 200 tested passengers in the previous 2 weeks. So that means that, you know, let me skip ahead. That means that if you wanted to predict 0 for everyone, right? Like if I just predicted that everyone would not test positive, I'm already getting 99.5% accuracy, right? But that's like a useless estimator because then I'm just like, we're all safe. Everything's great, guys. So go for it. So that's why I'm going to like label the 0 line here. This is we're looking at excess mean squared error on actual testing data. And we want to beat the 0 estimator, right? And if you just kind of did the vanilla estimate of positives over a total number of tests, you would actually do like much worse than that because, you know, there's a lot of variance here. So what we did instead was to use an empirical Bayes prior to share information across the different passenger types. So we sort of assume that every RKFT is sampled from a shared beta distribution, like a shared prior. And so basically what this does is if you have very few arrivals from a particular country, you would regularize that towards the population average. If you have a lot of arrivals, then you're able to get better estimates, and then we can actually get confidence intervals or credible intervals so that we can actually, you know, compute these Gittins indices, right? And that actually gives us this red dot. So out of sample mean squared error wise, this actually does pretty well. It does better than the 0 estimator. And then of course, it's like actually useful.
clarify here. So you actually effectively pool across different countries to reduce your variance. Do you now assume that in the past you learned that I don't know, the Spanish travelers were much more risky than the French travelers? Do you use that to correct for that, or would you still just pool naively?
So we're like assuming that the RK of T for each, so like our RK would be like the Spanish mean, the French mean, those are sampled from a shared beta distribution. So some of them will still be higher than others, but you don't want to use memory here, because what we saw is like a place would get really risky and then it would become much less riskier than other countries, because there's a lot of behavioral factors, right? Like if you're spiking, people start acting much more safely and then, the risk goes down. So like you wouldn't want to add a constraint like, oh, because Spanish travelers were safer than French travelers last week, that would still continue to hold, right? But basically the challenge was just making sure that this prior had like sufficient variance. And like I said, the counterfactuals we're going to compute are all based on inverse propensity weighting. So they're model agnostic. So there's assumptions we're making here to kind of reduce the variance of our estimates to do better out of sample. But when we evaluate it, it's agnostic to the estimator that we're using. Cool, I'm gonna move ahead. So there's like some issues with the type granularity. So like I mentioned, like an origin location has both country and city. If we did it at the city level, that would be great, because like, for example, New York City was a lot riskier than the rest of the US at this time. But then we have, like 17,000 arms on our bandit. We only have 7,500 tests. So that would like quickly become super degenerate. If we do it at the country level, that's kind of manageable because we only get about like 160 countries every 2 weeks. But then, there's some bias that we're not accounting for the fact that some places from these high-risk cities, like we're not accounting for that, right? So what we did was we kind of defined most types at the country level, but we isolated very risky cities kind of using lasso regression. So just to illustrate how this works, like let's imagine that this is the US or something, and there are maybe only 7 cities that people came from the US. The last 2 weeks, we see that this blue bar in this New York City, like people are testing positive at a much higher rate. And from these other locations, they're all like roughly close to 2 or something. So what we would do is we would have a lasso regression of whether or not people are testing positive. We would throw in dummies as features for like each city they could be coming from. And then we just look like, what gets picked up in the support. And typically, only the blue one will get picked up. Everyone else will be in the intercept term. So that means we'll define a new type for New York City, and like everybody else is like a different type, right? Like the rest of the US. Again, fake example because US was blacklisted. But basically this helps us trade off this bias and variance. Like we want to have city level information for risky places, but still have a manageable number of arms. Yeah.
But will you redo the segmentation regularly?
Yeah, so we read, excellent question.
Sorry, I was too slow, so you have to repeat. She asked whether you will redo.
Yes, well, we redo the segmentation every time period, basically. So we redid it every week. Because on one hand, we could have done it more frequently, but like the policymakers are kind of staring at the dashboard. So we didn't want to like wildly change the types. But it was the case that, cities that we would pick up, like we picked up a bunch in France, I think, like those would actually change in a non-stationary way. So you do want to update it. So that's what's great about running a non-stationary bandit. You can constantly change the arm space and everything's fine, right? Great question.
Is the city data self-reported?
Yes, everything is actually self-reported. They go through the customs, and so the assumption is people would not lie, but it is an assumption, and I think there were cases where people did lie. But yeah.
And what do you mean by lie? That they would say that they were not infectious?
I'm not going to talk about that while it's being recorded. I'm happy to talk about it offline.
So they would just misstate their status, right? That's what you mean.
Yeah. Kimon has some fun stories. I should ask him offline. But the assumption here is that it's accurately self-reported, and we are aware that that's. I think that's mostly true.
So wait, what is self-reported? That you are from New York and not from?
Well,
New
technically,
Brunswick, or is self-reported whether I'm actually sick on the plane or not?
oh, no. The passenger locator form collects the origin that you're coming from. And there isn't like a systematic way, like technically the customs agent is supposed to check whether you are accurately reported where you're coming from, but that wasn't always feasible.
So that's what we're talking about, lying my city, not because you don't ask people, are you sick or not? You just ask them, which city are you from?
Yeah, I mean, the assumption is they're not sick also, but of course they are sick because they're tested positive, but they don't know that they're sick, right? So that's not a feature that we would expect them to know. Where you're coming from, you should know, so you might misreport it.
I see. So I might know I'm coming from a very risky city, and then I lie about it because I hope that you won't test me.
Exactly, yeah. And like I said, when we're doing the inverse propensity weighting, like we can get a valid counterfactual, but we can't say anything about how much better one could have done, right? So like there's lots of ways you could have done better, had more accurate feature collection, had more feature collection, just had more tests and be able to do, like more accurate inference of types, right? So like should think of this as like a first step, but not, necessarily like the best that you could achieve, right? Cool, let me get to the evaluation. So again, we did inverse propensity weighting, which is like a really nice way to do counterfactuals because it's model agnostic. And the only reason we're able to do this is because every time a bandit explores, it's basically running an experiment, right? And because it's a non-stationary bandit, there's a lot of randomness in how it makes allocations, which means the inverse propensity weights are, like very well behaved, right? And so we actually find that our policy gets about an 85% improvement compared to random testing, which is what Greece was going to do before, in terms of the number of infections caught at the border, right? So this teal line here is basically like what happens if you did random testing. This pink line here is what happens if you did like our policy. So the teal line is the counterfactual, the pink line is what actually happened. And you'll see that we've segmented it into peak season and off-peak season. So in the peak season, we're doing 85% better. So just to contextualize this, we used about 7,500 tests a day at the border. If we had done random testing and we wanted to catch the same number of infections, we would have needed 14,000 tests at the border, which incidentally was like the testing budget of the entire country. So they wouldn't have been able to do contact tracing or domestic testing, right? And you'll see that it drops off to 36% in off-peak season. And that's because the improvement that we're getting really depends on how many arrivals are being tested, like what fraction, right? So in the peak season, we're getting a ton of arrivals, but we have the same testing budget. And so we're testing about, maybe 20% of them. And then in the off-peak season, like the arrivals drop, but the testing budget is the same. So we're testing a lot more people. And you can imagine that any targeted policy is kind of only useful when you have a limited testing budget. In the limit where I'm testing 100% of everyone that's coming in, like you don't need to target all policies get the same thing, right? And so we do much better kind of like when the resource constraint is sort of more stringent. And you might say, okay, like, why are you comparing to random testing? Random testing is very attractive because there's no financial or technical investment, right? You can just pull random people off of the customs line and test them kind of like TSA to the extent that you believe TSA is random. And, like that's like a very easy thing to do. But you can imagine making a similar financial and technical investment to do targeting, but not doing reinforcement learning, right? Like, so no bandit. We basically target based on public data metrics. So like the number of cases that were being reported, the number of deaths that were being reported are like positivity metrics, right? And so what we see is we get about 25 to 45% improvement compared to these metrics. And this is where the censoring shows up. So we do like 45% better if it's cases, because cases were highly noisy depending on how much people were testing in different countries. Deaths is less noisy, so 37% better than deaths. And then positivity is great because they actually control for the number of tests that are being done. So we do only 25% better than positivity. But all of these boosts are free, right? So like at the point where you've already built this infrastructure, you might as well use reinforcement learning. So this is like the value of like just a better algorithm, right? Whereas this is the value of, doing a lot more work plus better algorithm. This is technically still an underestimate in these counterfactuals because behind the scenes, there's also a gray listing process going on. So if you imagine what a bandit does is it wastes a lot of time and budget exploring. so that when you find a high reward arm, you get to exploit it, right? Whereas what we do is when we find a high reward arm that's a risky country, we tell the office of the prime minister, hey, like maybe don't let people from this country come in anymore, especially without a negative PCR pretest, right? So we're kind of like, you know, screwing ourselves over. But obviously it's like the responsible thing to do from a public health perspective. So if we try to include that in the counterfactual, this is a much harder counterfactual to get because you can't use propensity weighting. You kind of have to forecast how much you think people would have arrived had you not gray listed them and what their risk would have been. If you try to do this exercise, we get about a little bit over a factor of 2 improvement based on the 10 countries that were gray listed by AVA during the summer. Okay, do I have time?
You still have 5 minutes.
Okay, cool. Maybe I'll very briefly say what happens with public data. So most countries, so this is Elon's question, most countries reported cases, deaths, and testing rates publicly. And so we tried to do a very simple exercise where we use that time series information to predict whether a country is risky. And this is just one possible classification exercise. We did a bunch, but let's say we're interested in looking at whether or not they have a risk of more than 0.5% chance of testing positive. That's usually when we started telling the PM, like maybe we should gray list the country. So it's like a policy relevant outcome variable. And you'll see this is like an AUROC curve. And pretty much all the models we tried had like 0.5 AUROC. So they were complete crap. Like they didn't have any predictive power. And this model 5 is like a little bit better. It gets a 0.622 AURC, which is also not great. But basically this one leverages country-specific fixed effects. So like I include the fact that this is UK or this is Germany in my model. You can't learn this model without actually collecting the data that we collected. So basically this is just saying that like you couldn't have done this with just public data to accurately predict what the risk would be in Greece. And this is because if you actually do a scatter plot of this, on the x-axis, we're looking at prevalence as measured at the border from our data. On the y-axis, we're looking at new cases per million as reported by public data. You would imagine that this would be like a fairly straight line or at least like a positive correlation, because if a country is riskier on public data, you expect it to be riskier at like our border. But that was like clearly not the case. It's not even clear this thing has positive correlation. And there's like a number of reasons that we hypothesize. We don't know the mechanism, but the testing strategy typically censors data. So like usually countries are testing, you know, high risk symptomatic patients, like older populations. People coming to tourist in Greece are not those people. Often there's also delays, and the delays are country specific. So this is an example of a country that I can't name. But you can see that in our lab data, they spiked, you know, kind of in the beginning of August, but in public data, they didn't actually spike until like well later. So there's infrastructure delays in different parts of the world, which means that they might not actually reflect when like they're risky until, you know, things actually happen. So case reports we found were typically delayed 1 to 16 days, depending on, you know, the country. So not accounting for that and not having information on that a priori, like obviously also hurts your ability to preserve public health.
So at that time of COVID, how long would it take to die from testing positive? So did you, I mean, are these long delays essentially now they're deaths and you can't deny it anymore? Or?
It could. So these we're looking at cases per capita, like when we're looking at these measurements. But yeah, I think the time to death, I don't remember exactly, was about 10 days or something. But again, that's not the right population for us because we're looking, the tourist population is very young and asymptomatic. So the death rates there were very low. But yeah, within the country, like, yeah, I'm not sure. That was a long answer for sure. But yeah, that should be it.
Depend on the country, right?
Right.
Have different death rates.
Yeah, so in the US, there was also the attribution issue, like what counts as a COVID death? Because if you never tested the patient and they died, like, are they really a COVID death? I remember like Pennsylvania struggled a lot with the attribution issue, and that would change wildly too. So I don't think we can say, yeah.
If I know the prevalence scale, I can guess what country it is that you're not being.
No, don't look at it.
No, yes.
You're gonna get me in trouble.
No.
So there were other things, I think I'm out of time, but there were other things that happened.
But
like,
your talk is not differentially private.
Yeah, it's not. I should take a class on differential privacy. There were other things that happened, you know, in terms of designing the testing supply chain, like that happened in the background. I'm not going to talk about it, but basically, like, there are constraints about like where we should allocate staffing, like where we should allocate tests. This is actually isn't in our main paper, but it's sort of in our applied analytics paper. There's different objectives thinking about transportation costs, like complexity of border operations. So like PCR testing, there were dry swab and wet swab PCR machines, and like having both in the same port like made it difficult to like collect data. So depending on the lab that they were serving, like there were a lot of issues about like maintaining, like keeping that complexity kind of under like wraps. And also there's this interesting effect, which is that if you're thinking about allocating tests and you're looking at the percentage tested, if you're using random testing, if you're using something like reinforcement learning, the initial tests kind of have a higher bang for your buck, right? Because you're testing like the riskiest passengers. And then as you test more and more people, like the value kind of diminishes. But then if you were doing random testing, this would be like a straight line, right? So this actually means that when you're allocating your testing budget, you want to allocate more tests to places that have very heterogeneous populations, because it's more likely that you'll be able to get this extra bang for your buck. If you know only Germans are showing up there, then like probably you're closer to this line, right? So these are considerations that we had to do kind of before we actually even bothered, before we actually started the system. So like imagine that entry 17 like has like a lot of heterogeneity, then we expect that their prevalence will kind of have like a higher tail. So that means that their lift over random testing will be much higher than like entry 6's lift over random testing, which means that we should actually allocate more tests to entry 17 because we anticipate that they'll be able to take more advantage of heterogeneity compared to.
So did you do, that was actually a question I had but didn't ask. So as you do your testing, you might actually say, you know what, we need more tests in essence. Did you do that?
We couldn't do that. We tried really hard to do that, but these are like fairly significant financial contracts, and staffing is like also a big logistical problem. So they were very unwilling to actually change that during the course of the summer. So it was a one-shot decision and obviously leaves money on the table, but it was not something we were able to budge them on. But yeah, so then there was like some like dashboard work about trying to visualize the trade-offs between, you know, like the number of infections we could catch versus like the complexity of this testing supply chain. And so we would show them like different plots, and, you know, generally they prefer less complex so that they can actually follow up on these things, you know, and, you know, ensure that things are actually going smoothly. So there's like, I think in any of these policy projects, some work to be done on like being able to visualize things that are like generally hard to quantify or visualize, right? Like if you just show that, if you just tell them like, oh, that's the complexity of the network, they don't get it. But if you show this plot, like it kind of makes more sense. And that's it. I think there's a lot of exciting opportunities to use these kinds of tools to improve lives. Like we're doing some work with Sierra Leone and DRC to try to improve national distribution of health products. And also working with law enforcement to identify human trafficking cases from deep web data using kind of similar tools, which we're pretty excited about, and I'm happy to talk about outline. Thank you.
Okay, I think we had a lot of questions, so let's.
One more.
Okay, okay.
Can I borrow?
So thank you. I mean, this was really a fascinating presentation, and I must say that it made me think about some of the work that, you know, my group has done at Ohio State in the context of testing students. These are different types of tests because we were doing continuous testing, so we were retesting populations. But basically, the following question and a comment. You know, in general, the types of problems that you're looking at, these are so-called, it seems like these are stochastic Markovian optimization problems, because you're assuming that you don't have memory, you have some kind of Markov process that you're following, you have some time of emission probability, meaning you're not observing the actual state, but you're observing a surrogate. And that basically gives you a way of making inference about the hidden variables. So there are basically two elements to this. The one is called hidden Markov models, which is a very well-known area that's studied in the engineering community. But there is also this more general theory related, which is called the dynamical programming. And it goes to something which is called Bellman's optimality principle, which in the stochastic setting, roughly speaking, means that from step to step, you can build up a maximum likelihood estimator in some sense under constraints.
Right.
So just out of curiosity, are these the types of, so how would some of these solutions that you have here compare to just straight application of these Bellman optimality principles in the Markovian setting?
So the Gittins index is actually the solution of a dynamic program, like using Bellman's operator. I think usually the issue is that typically these problems you have full feedback, whereas we have banded feedback, right? So you don't actually get to see like whether or not someone is testing positive unless you actually test them. So that's what the Gittins index literature is sort of on. And it turns out these dynamic programs in the presence of banded feedback are highly computationally intractable, which is why people came up with these kind of, simpler heuristics like upper confidence bound and Thompson sampling that have like these nice asymptotic, like low regret guarantees. So we're sort of, but that's exactly why we tried to build on the Gittins index policy because, it has some like optimality notion. Yeah.
Right.
Yeah.
So I think that's really interesting that you can do this sort of in a sensible way computational, right? Because this is always a problem.
Well, we won't take any credit for that Gittins thing, but yes, I think that was kind of a big result.
Okay, thank you.
Yeah, thanks.
See you all back in